David, how does it feel to be the odd man out here on this four-person, three-women panel?
Okay, well, Vicky, you forget I'm the father of three daughters.
Oh, you see, there you go.
So this is, I don't know anything else.
Well, then you got to start counting the gender of the animals in the house to see where you lay in, majority or not.
That's right. Well, that's why we got the bulldog.
Okay, I think we could start now. To start with the introductions, I want to thank everyone for attending this seminar. As you know, as it's been advertised, tonight is the first session of a series of medical school for lawyers. You don't necessarily have to attend the first one to attend the second, third, or fourth. And you don't have to necessarily attend any one particular course. You can choose which course you want to take and choose other courses that you don't wish to take. So they're really all individual. And this is the first series. There will be other series. And we wanted to really emphasize that this is not a course for medical malpractice attorneys. This is a course for all personal injury attorneys. This is a course that's going to teach everyone about basic medicine in all of the areas of medicine. So like, for example, this is basic anatomy and emergency room medicine. The July 12th course is orthopedics and radiology. There will be subsequent courses on spine and pain management, neurology, gastroenterology, urology, all areas. And it's really important because when you know exactly what your client is going through and you understand the injury, you are a better advocate to both the defense attorney and the carrier. And ultimately, if that doesn't work, ultimately to the jury in explaining the items of damage that your client had suffered as a result of the negligence of the defendant. And that's the purpose of this seminar, to get everyone intimately familiar with the basics of medicine. So I would be remiss if I didn't mention that this brainchild came from years ago, Gary Pillardorf's course that he used to give at Mount Sinai Medical Center. I was too young to attend such a course, but I've heard great things about it. And I felt that it needed to be reprised. And that's the purpose of my bringing this all together for tonight's first session. What we've done, I didn't even introduce myself, not that that's important, but I'm Victoria Wickman for everyone who doesn't know me. But what we've done here is we've collaborated with the Expert Institute, and Dr. Wendy Kettner is here from the Expert Institute. You're going to learn more about what that institute does, but I can tell you that I did a session today to learn more about it and blew my mind, like completely blew my mind, to put us at a level playing field with the access of information and knowledge that the defense bar has. I'm going to leave that for David to talk more about, but I would like to take this time to introduce my esteemed co-chair, David Otto, who needs no introduction at all. As a former past president of New York State Trial Lawyers, he is a partner at Otto and Babbitt. David has been listed as some of the top verdicts in the state of New York. In 2020, he obtained the highest medical malpractice verdict for that year, $15 million for a stroke victim. He's been top lawyers Northeast, top lawyers New York. He has been named in the City and State magazine's 50 over 50. He is the author of Medical Malpractice and Wrongful Death, Answers to Tough Questions That Can Arise in Your Case, published in 2021. I guess that's what he was doing during the pandemic. And additionally, he also has a podcast called The Trial Brief, which is available on Spotify and Apple Podcasts. So without further ado, I introduce to you David Otto.
Thank you, Vic. And Vicki, we all owe you a thank you for putting this together. This was, I unfortunately am not too young to remember this course that Gary Pillardorf taught. I went to it as a young lawyer, and I maintain that is the the best courses I ever took. They were the most important courses I ever took. And they for you to do this and spearhead this again, I think is going to be a benefit to not just medical malpractice attorneys, but to personal injury attorneys as well. So thank you, Vicki. This is great. Okay, so I have the pleasure of introducing Dr. Wendy Kettner, and Dr. Kettner is the senior vice president of medical affairs at the Expert Institute. Dr. Kettner completed her internship and residency at Beth Israel Medical Center here in New York City, participating in all aspects of general surgery, routine hernia repairs, cholecystectomies, appendectomies. Her research was in post-mastectomy reconstruction and the surgical treatment of gastric cancer, on which she co-authored a textbook chapter. I've had the pleasure and really the honor of working with Dr. Kettner through the Expert Institute. And I can tell you that, the Expert Institute has, which, Dr. Kettner will tell you more, but my personal experience is that, they recently saved me on a case I was about to walk away from. It was a very unique, rare bacterial infection where I needed a certain expert, and they were able to locate probably the one and only expert I could have used. And they located this expert, and I was able to obtain a 7-figure verdict back in November of last year. So I'm a big fan and a big believer, and I'll let Dr. Kettner tell you more about the Expert Institute. But I really encourage you to go on to learn more about them and go on to the website. Anyway, without further ado, Dr. Kettner.
Thank you so much, David. And Victoria, I echo special thanks to you for putting this together and asking us to participate. We're so excited about it. Next slide. So a lot of people, because we have 60 MDs on staff at Expert Institute, think that we only do med mal, which, as Victoria mentioned, couldn't be further from the truth. Next slide. So we work on experts in all types of cases, all PI, so slip and fall, MVA, premises liability. We work on employment law, elder abuse, sexual abuse, nursing home cases, workers' comp. It really runs the gamut. Every day, our 100+ researchers are finding experts in accident reconstruction, engineers, life care planners, dog behavioralists, coefficient of friction experts. We found an expert last week in Canadian geese migratory patterns that were flying across the highway and causing accidents. So if it's out there, we will find it for you. Briefly, our process is a little different than other companies that you might have worked with. We do not have a stable of experts. Those 100 researchers are custom recruiting the perfect expert for your case. We also don't have any financial relationships with the experts. So we don't pay them anything, they don't pay us anything, and we don't mark up their rates. Lastly, and maybe most importantly, we have a very rigorous screening and vetting process. So by the time their CV hits your desk, they're ready to go, willing to go all the way to trial and be your expert. Next slide. I want to touch really briefly on our newest product called Expert Radar. We have really poured our blood, sweat, and tears into this. No one has the amount of information on any given individual. It could be your expert, an opposing counsel's experts, a defendant. You could even plug in a juror or a judge if you wanted to. It's divided into sort of 4 different categories. The first is their professional information, which includes everything from employment history, conferences they've spoken at, their certifications that are active and lapsed. It's basically their CV on steroids. The next is litigation activity, which has all of the cases that they've been an expert in, who they testified for, the details of those cases, the representation on both sides, depositions, exhibits, their personal litigation if they've been sued, Daubert-Frye challenges. It's really detailed information. The third is risk and credibility. This includes sanctions, background check, DUIs, traffic tickets, We found someone doing insider trading, all of their social media, all of their YouTube videos. And the last is insurance claims. So you can actually see how they stack compared to their peers in terms of diagnoses that they're treating, as well as procedures that they're performing.
Let me just jump in right here. This was what I learned this morning when I saw it with my own two eyes. Dr. Kettner just explained it briefly. But the amount of information that they have been able to dig up on basically any defendant expert is incredible. It is exactly what the defense finds on our clients. When we are at a deposition and they find out about some traffic infraction from 2001, and you wonder how on earth did they find out about it? This is the same type of database that the doctor has, but for us to fight for our clients, it sort of level the playing field.
Thank you, Victoria. Yeah, and the best thing about this is that it's not a static report that we send to you. We monitor it for you. So if they get a DUI, and this could be, again, your expert or the opposing counsel's expert, you want to know both information. If they switch hospitals, if they let one of their license lapse, if they put out a new publication, you're going to get an email from us saying, log in and look what's changed about this expert. So why we're here today, I will keep moving. We want to showcase our 60 MDs and what they do. And we really like you, to think of us as sitting down the hallway from you. We're available for quick questions. So perhaps you have a client in an MVA and 3 days later they have a heart attack, or a couple hours later they have a second trimester miscarriage, and you want to just pick up the phone and talk to a cardiologist or an OB. And explain the fact pattern and see if you have causation there. Maybe an umbrella flies up, hits someone in the head at Starbucks, and they get a cataract. Is this even medically possible? Does it make sense? Should I spend money on this case? Should I just turn it down? That's what we're here for. We also do full medical record reviews, but even that can be, for a number of reasons. Sometimes it is a med mal for merit, but oftentimes it's an eggshell client where defense is trying to say everything's pre-existing. We can get you on the phone with our orthopedic surgeon, our spine surgeon, talk through each of the injuries. Our goals are totally aligned, and we think like plaintiff's attorneys. We want to get as much money as possible back into your clients' pockets. I mentioned the 60 physicians, 20 of us are full-time like myself, 40 are actively practicing and help us with these case reviews. Dr. Madeleine Hawkins, who we have, is one of them. She's fantastic. We're so lucky to have her. She is a board-certified emergency medicine room doctor in Chicago. She's an attending at HSHS St. Anthony's Memorial Hospital, and she has reviewed cases actually since residency. She's part of the sepsis team at her hospital, as well as on the Quality Control and Patient Safety Council. So she's very experienced with this. Above all, she's a fantastic teacher. So I'm going to pass the mic to her and we can get the main program started. Thank you for being with us, Dr. Hawkins.
Thank you guys so much for having me. I'm excited you all logged in for this presentation. It's a lot of information, so I'll do my best to get through it.
And before she starts, I just wanted to state that everyone who's registered could be, we don't really know what medical basis or foundation it is that you have. It could be from absolutely no medical knowledge to more medical knowledge and very good medical knowledge. So our goal right now is to, Dr. Hawkins is going to do her best to teach it as if you don't know anything about medicine. But there are some things David and I can attest to that may be a little bit difficult to comprehend. There is a Q&A down at the bottom. If anyone has any questions that arise during the presentation, please feel free to ask your question in the Q&A. If David and I can answer it, we will. If we cannot, we are allotting a certain amount of time at the end to have Dr. Hawkins answer those more difficult questions. Without further ado, continue, Doctor.
Thank you. So yeah, the goal is to kind of give a basic introduction to anatomy. We're going to cover the chest, abdomen, and just touch on the brain slightly. First, I do want to start with the medical record. When we get a printout of these records, it contains a lot of information. It's going to contain triage notes, nursing notes, a lot of other stuff, as I'm sure you know. The thing that I go to first, though, is the provider history and physical. And the history and physical is going to have a lot of abbreviations in it. So I just wanted to touch on a few common abbreviations. We like to use abbreviations in medicine. So here are some common ones. CAD is going to be coronary artery disease. I'm not going to read through all of them, but MI is going to be myocardial infarction. More commonly, we actually use ACS now, but you could see both of them. ACS is acute coronary syndrome. Another one is S/P. That means status post. So if someone had a gallbladder infection and they had their gallbladder removed, you could see in the chart cholecystitis, S/P, which means status post cholecystectomy. So they had a gallbladder infection, they had their gallbladder taken out. HTN is going to be hypertension. So here's just a list of those common abbreviations. The history and physical is going to contain 5 things. The first thing is an HPI, that's a history of present illness. This is where the provider should describe the patient's symptoms, when they started, if the pain is sharp, dull, etc. There's also a review of systems. This is just what it sounds like. It's a checkbox of other symptoms. It may mention fever, rash, headache.
Doctor, a lot of what comes out at trial is who provides the HPI? Is that a doctor writing it on behalf of someone else? Just explain that to the jury, because that comes out to the audience, because that comes out a lot also.
Yes, the HPI, the initial, we call it chief complaint. The initial reason they're there should be in the patient's own words. So the patient states they came in because my stomach hurts, and usually I'll put that in quotes. And then it's the physician asking questions, but it should be what the patient is telling them. It's sharp, it's on the right side. So patient explains the pain is sharp on the right side. It should be a physician's documentation of what the patient is telling you. The MDM, which is on the bottom here, that's the physician interpretation. So that's where they should explain, I think it's this, the pain is consistent with, it's on this side of the body, which I'll go into. So I think it's this. Because I think it's this, I'm gonna run these lab tests or do this imaging. The MDM is where the physician should really explain their own thought process.
Is that sort of the same thing as a differential diagnosis?
Yes, the MDM should include the differential. It's as part of it. And then the other 2 parts of the history and physical are going to be the vitals and physical exam. I was always told in med school, vital signs are vital. So we're going to go through all the vital signs. There are 5 of them: blood pressure, heart rate, temperature, respiratory rate, which is how quickly a patient is breathing, and then oxygen saturation. All of these can be high or low, except oxygen, it can't be over 100%. The first one I'm going to talk about is blood pressure. So low blood pressure, the other name for it is hypotension. It's usually when the blood pressure is less than, anywhere from 90 to 100 over less than 60. You can have low blood pressure that's reversible, but when low blood pressure causes issues with blood flow to organs, that's called shock. So throughout this lecture, I kind of want you to keep in your mind that oxygen is necessary for all tissues. So you have to have oxygen for tissue to be viable. If it doesn't have oxygen for whatever reason, lack of blood flow, the blood's not getting oxygen. If it doesn't have oxygen, the tissue will start to die. And so whenever you have shock, you're having no circulation in your body. So you're not getting blood delivered. So you're having tissue hypoxia. And that is what shock is. There's different types of shock. They're listed over here on the right side of your screen. And I will go, when we go through the anatomy, these will kind of make more sense, but just to touch on them briefly. Cardiogenic shock, cardiogenic meaning heart, is basically when the heart doesn't squeeze very well. So it's not getting blood to the body. So then blood's not going to be delivered, oxygen's not going to be delivered. Hypovolemic, that's pretty self-explanatory. You don't have enough blood volume. That's usually from bleeding, like a trauma patient would have a lot of bleeding. They would have low blood pressure. They would have hypovolemic shock. Distributive shock, this is a broader term. It does encompass septic shock. So basically, in distributive shock, you want your blood volume to be in your veins and in your arteries. For distributive shock, the body gets confused and basically it starts putting the fluid on the outside of the veins and the arteries into the soft tissue and this space we call third space. So if a patient is third spacing, that means the volume that should be in the veins and the arteries is being redistributed to the wrong parts of the body, and you're going to have low blood pressure. Obstructive shock, again, this will make more sense in a little bit. I'm going to touch on it, but basically the heart is being blocked from filling. And so if the heart can't fill, then it's not going to pump blood to the body. So you're going to not deliver oxygen, and that's going to result in shock. And then neurogenic shock, that's actually complicated and it's pretty rare. I'm not going to really touch on it in this lecture, just know that it exists. The opposite of low blood pressure is obviously high blood pressure. That's called hypertension. This is usually when the blood pressure is greater than 160 to 180 over 100 to 110. So in emergency medicine, this is going to be kind of dedicated more to emergency medicine because that's my specialty. In emergency medicine, the numbers don't mean as much. You know, obviously if a patient has a blood pressure of 180 over 100, I do want to give some medicine and bring that down. But in emergency medicine, we worry about something called hypertensive emergency. And that is when the elevated blood pressure is causing organ damage. We always worry about damage to the organs. And so hypertensive emergency is when you have an elevated blood pressure and that blood pressure is causing issues. So the patient could be having chest pain, heart attack related to that. In that scenario, that is where we'd want to bring the blood pressure down more rapidly compared to hypertensive urgency, which is just an elevated blood pressure, no symptoms. You know, I checked my blood pressure at home, it was elevated. That causes issues over time. Yes, you do not want a patient's blood pressure to be 160 over 90 for months and months and months. That will cause issues long-term. But as it relates to emergency medicine, we care about when there's end organ damage. And then moving on to the next vital sign, heart rate. So obviously your heart rate can be fast or slow. Fast heart rate is usually greater than 100. We call that tachycardic. This is all in adults too. Obviously children are going to have different vital signs. This is pertaining to adults. So tachycardia is going to be a heart rate over 100. It can be if you don't have enough volume. Infection can cause your heart rate to go up, fever, and a pulmonary embolism, which we'll talk about.
Slow pain, correct?
And pain, yep. A slow heart rate is going to be less than 60. That's called bradycardia. It can be physiologic. If you're a young, fit, healthy person, you may just have a lower heart rate at baseline. A more dangerous reason would be a heart block. That's a little bit complicated, but that would be a dangerous reason. Or patients are on certain medications to keep their heart rate slow, such as a beta blocker. If a patient was on that, their heart rate will be slow. We measure heart rate with an EKG, and I'll talk about EKGs a little bit later on. Another vital sign is temperature. I think people are probably most common or most familiar with a fever. A fever is going to be greater than 38 degrees Celsius. That's 100.4 degrees Fahrenheit. A fever is actually part of the body's natural immune system's natural response to an infection. Once you get an infection, your body will recognize it and it will start attacking the infection. When it starts attacking the infection, it releases these things called pyogens. You don't have to know that word, but basically they travel to this deep part in the brain here called the hypothalamus. And the hypothalamus will start to purposefully increase your body temperature to try to make you like an inhospitable host for this virus, because the virus doesn't want the body to be warmer. So that's part of the natural immune response to having an infection. It's for your brain to tell your body to increase your body temperature. So usually your hypothalamus will self-regulate, and usually it will not create a dangerous fever if it's just coming from the hypothalamus. Your body usually does not increase your temperature to greater than 105.8. The way you get dangerously elevated body temperatures is if you have an external source. So if you're stuck in a hot car, out in the heat, some medications, some drugs can do this, and some withdrawal from drugs can raise your body temperature to that dangerous level to about 108. That's when you really start getting brain damage from a fever. But usually you have to have an external source that will raise your temperature like that. Hypothermia is a little bit different. Hypothermia, there are ranges of hypothermia that that will change your body's function as your body temperature decreases. Hypothermia, again, is most commonly due to an external factor like being stuck outside in the cold. So when you get to a mild hypothermia, which is like 32 to 35 degrees Celsius, this is like 95 to like 89.6 degrees Fahrenheit. We know that you'll kind of start shivering. Once you get down to below 28 degrees, which is like 82.4 degrees Fahrenheit, that's when you can become unconscious. You can have all of these changes, and that would require rapid rewarming in the emergency room. Oxygen saturation and respiratory rate are the last two vital signs. Adults typically breathe between 12 and 16 breaths per minute. And oxygen saturation, it's usually around 98%, but it can be normal as low as 92%. Tachypnea, that means you're breathing fast. Usually it's like a respiratory rate 20 and higher. So I just want to touch on oxygen because like I was saying earlier, oxygen is just very important. All the tissues in the body require oxygen. Oxygen is actually carried on iron. And this is a little complicated, but just to understand, this is called the hemoglobin molecule. Hemoglobin is carried in red blood cells. There's hundreds of hemoglobin per red blood cell. Each hemoglobin molecule carries 4 oxygens on its iron. So when we're measuring oxygen saturation, we're measuring how much hemoglobin is saturated with oxygen. Okay, so now we're going to move on. Those are all the vital signs. We're going to move on to a patient case. The most common presentation to the emergency room is chest pain. So we're going to go through, we have an elderly gentleman here with chest pain. When people with chest pain come to the emergency room, you know, usually they say, am I having a heart attack? They want to know if they're having a heart attack, which is a reasonable question. But what even is a heart attack? We know it's when the heart doesn't get enough blood supply, but how does the heart even get blood to it? And that's what we're going to go into today. So just to start with the basics, first, the heart is a muscle. And so remember, any tissue needs oxygen. The heart needs oxygen. The heart sits in the center of the chest, and it actually sits between the 2 lungs like this. So this is kind of the chest cavity cut in half. The heart sits just between the 2 lungs. It's divided into 4 chambers. You have the right side of the heart, which is divided into a top and a bottom, and you have the left side of the heart. When we discuss anatomy, I should have said this earlier, when we discuss anatomy, everything is flip-flop. So the left side of the screen is the right side of the body, and the right side of the screen is the left side of the body. So this is the right, this is the left. The heart's divided to the right side, the left side. You have a top, this is called the right atrium, right ventricle, left atrium, left ventricle. Even though it's divided into 4 chambers and a right side and a left side, the top part of the heart actually works together. So the atria work together and the ventricles work together. And I will go through that. Oh, the heart too, when it pumps, when it squeezes blood, I wanted to show you a picture of the aorta. So this is the aorta. It's basically a blood tube, and it runs the entire length of the body. And I'll be kind of touching on the aorta quite a bit throughout the lecture. So just know that the aorta runs the entire length of the body. So to go into the heart a little bit more, blood is drained from the entire body via the veins. So the veins carry unoxygenated blood from the entire body. And eventually all those veins drain to form a superior vena cava and an inferior vena cava. The SVC and the IVC drain into the right atrium, and then blood drains from the right atrium into the right ventricle. And this came from the veins, so it doesn't have any oxygen. So then it gets pumped from the right ventricle into the pulmonary artery, and then it goes into the lungs. So then blood goes through the lungs, gets oxygenated, and then it drains via the pulmonary veins into this left atrium. Blood goes from the left atrium to the left ventricle, and the left ventricle is very strong, and it's bigger than the right. It's very strong, and it pumps blood up and out the aorta to the entire body, down that blood tube that I mentioned earlier called the aorta. Okay. So back to our question, where does the blood, or where does the heart get its blood supply? It actually gets it from two branches off the aorta. So this is kind of the outside of the heart, not the heart cut in half anymore. And you can see this right here is the aorta. Right where the aorta starts, there's a branch called the left coronary artery. Coronary means heart. The left coronary and the right coronary. The left coronary splits and has its own branches, and the right coronary splits and has its own branches. So the heart squeezes, pumps blood out the aorta, and pumps blood back to itself on the outside of it via these coronary arteries. When you get a blockage in the coronary artery, that is a heart attack. So when you get a blockage via plaque or a blood clot, that is a true heart attack, a myocardial occlusion. There are two types of heart attacks. There's a STEMI and an NSTEMI. To understand, I don't expect you to look at an EKG and diagnose these, but just to kind of understand what, when we say NSTEMI or STEMI, just know that the heart has an electrical system. So the heart has an electrical signal that tells the muscle to beat. And this electrical signal happens in a very specific pattern. So when you get a blockage in one of the coronary arteries, the tissue is not going to get oxygen. So the heart muscle is going to start to die. If that muscle dies so much that it affects the electrical conduction system, you're going to see those changes on the EKG. And so that's where you're going to see a STEMI. So that's why we consider a STEMI a worse heart attack, because it's causing the muscle to die in such a way that it's affecting the electrical system, so that when we do that EKG, you see EKG changes. That's the difference between a STEMI and an NSTEMI. An NSTEMI, in theory, it's a smaller heart attack because there's tissue death, but not enough to affect the conduction system of the heart to cause EKG changes. However, though, I just want to kind of mention that terminology is slightly changing. I think we're going to start to see called OMIs, occlusive myocardial infarct, which just means the patient has severe chest pain. They need this blockage. What happens for a heart attack? They go in and they open that blockage up. So I think we're going to see a slight change in terminology to OMIs, occlusive myocardial infarct, and see less of these STEMIs versus NSTEMIs, because all blockages are bad. And this is just a sample of an EKG, just the electrical rhythm. And this is what we measure when we're measuring the electrical system of the heart. So back to our patient is getting low blood pressure. We talked about low blood pressure earlier. One of the reasons you can have low blood pressure is if the heart isn't squeezing. So like we just talked about, if you had a blockage and the heart muscle died, it's not going to be as strong, it's not going to squeeze. You could definitely have cardiogenic shock. But another shock we talked about is something called obstructive shock. And that is basically blocking the heart from filling. So when blood goes into the heart, especially the left ventricle, it does stretch just a little bit. Kind of like a balloon, it stretches just a little bit to give itself some stretch to give a good squeeze. So if there's something blocking the heart from filling with blood, it's not going to get a good squeeze, and it's not going to fill with blood to pump blood throughout the body. So in that, one of the reasons you can have obstructive shock is if there is, remember the heart sits between the lungs. So you can actually get air between the lung and the chest wall. And that's called a pneumothorax. So you can, basically the lung, like this side, should be pushed up tight against the chest wall. You can get air in there for lots of different reasons, but once you get air in there, it's going to start to push and collapse the lung. So I'll show you, this is just a normal chest X. I just wanted you to see what it looks like. You can see the lungs here and the heart right in the middle, but this is a pneumothorax. So you can see this is the edge of the lung right here. And this should be up against the chest wall. You can imagine if this air is pushing so hard, it's collapsing this lung, it could even push so hard to collapse the heart. And that's what's happening here. You can see the entire heart is pushed. So you could imagine there's so much tension on the heart, it's not going to be able to fill. And this is actually called a tension pneumothorax. This has to be treated promptly. You basically put a tube in and drain the air out this way. But that's another reason you can have low blood pressure and chest pain in the emergency room. Another reason the heart can be blocked from filling is, to understand this, just know that the heart sits in a sac. So the heart's not just swinging around in the chest, it actually has a protective layer. And this goes around the whole heart, and it goes on the outside of the coronary arteries too. But this is called the pericardium. It's a lining of the heart. You can get fluid in the or inside the pericardium surrounding the heart. That's called the pericardial effusion. So obviously, again, the heart wouldn't be able to fill because there's fluid there. This is called an echocardiogram. It's an ultrasound. Don't expect you to be able to interpret ultrasounds, but I just wanted to show you, and it's a little upside down just because of the way the ultrasound is done, but just wanted to show you that the heart truly does look, like these drawings. You can see the right atrium here, you can see the left ventricle here, and this is fluid around the heart. Another good way to see fluid around the heart is, this is a CAT scan. So you can see the heart here, and then you can see this giant circle of fluid. That should not be there. That's a pericardial effusion. Okay, so back to our patient. Now he has low blood pressure, he has chest pain, and he's breathing fast. So when a patient's breathing fast, we always want to think about the lungs. So move on to the lungs. You can get, just like you can get a blockage in the arteries of the heart, you can get a blockage in the arteries of the lungs. And this is called a pulmonary embolism. An embolism is a blood clot that travels from somewhere. A thrombus is a blood clot that was formed where it started. So when we talk about a DVT, a deep vein thrombosis, that means the clot was formed in the lower leg. And that's what happens commonly with a pulmonary embolism. You get a deep vein thrombosis, which is a blood clot in the, so obviously this branches more and more into a bunch of veins in the calf. And commonly you get a blood clot that forms in one of the deep veins of the calf. And it can travel from the deep vein. Remember we talked about all the veins drain into the IVC and the SVC. So what happens is it drains into the IVC. And you can actually have a blood clot that extends like from the calf all the way up here. Those would obviously be more dangerous, or you can get a small one down here. But it travels up the IVC, into the right atrium, into the right ventricle, and then the right ventricle drains into the pulmonary artery system. The pulmonary artery system is going to be much smaller than these calf veins, so you're going to get a blockage, and that's called a pulmonary embolism. And obviously that can cause all kinds of issues with oxygenation. And remember, we need oxygenation so that blood can go to the left side of the heart and go throughout the body.
Dr. Hawkins, is there any incidences or correlation between ankle fractures and pulmonary emboli?
Yes, absolutely. And hip fractures. So now I believe it's common practice to, if they're going to do a hip surgery and you're an elderly patient, they actually start you on blood thinners, even just an aspirin sometimes, to try to prevent blood clots from forming. Because if you're the way you get a blood clot in your calf, most commonly, you can be predisposed to them and everything, but most commonly is from immobilization. If you're not walking, not moving much, you can get a deep vein thrombosis in your calf. And this, so there are a couple ways to treat pulmonary embolism, but sometimes they go in and pull them out because they're causing such issues. And this is what a pulmonary embolism looks like when you pull it out. And you can see the branch. This is what we call a saddle embolus because it covers the main branches, and you can see like it branches like the pulmonary arteries. Okay. So we talked about blockages. We talked about obstructive shock. The next thing that can happen is you can actually get a hole in something. So the aorta, which I've talked about quite a few times, it's the giant blood tube that runs throughout the entire body. You can get a tear in the aorta called an aortic dissection. The aorta is a few different layers. An aortic dissection is when you get a tear in the innermost layer. So blood escapes the important part of the aorta and kind of leaks around to the outside. And this can cause obviously many, many issues because it supplies the entire body. So depending where the tear is, it can cause a lot of different issues, and it can cause obviously you to have low blood pressure or high blood pressure. An aortic dissection, it can be a bit complicated. So back to our patient. Oh, this is a CT showing of an aortic dissection. So this line shouldn't be here. And again, I just want to show this because you can see the entire length of the aorta. This is down the entire body. Back to our patient. So now he's starting to breathe fast. So we have a patient with chest pain, low blood pressure, he's getting a fever, he's breathing fast. There's one other thing in the chest wall that we haven't really talked about, and that is the esophagus. So, it's kind of the swallowing tube. It connects the mouth to the stomach. And just like you can get a hole in the aorta, you can get a hole in your esophagus. And that's called Borehof Syndrome. It can be from forceful vomiting. It's linked to patients who suffer from alcohol dependence and have significant vomiting. But most commonly, it's what we call iatrogenic, which just is a fancy way to say that it's caused by a procedure like an EGD or something.
An endoscopy, right?
Yeah. Oh yeah, endoscopy. We like our abbreviations. So back to our patient. Our patient was hypotensive, tachycardic, febrile, and breathing fast, tachypneic. Those are all indications that he could have sepsis. I want to touch on sepsis here. It's kind of big in medicine right now. With sepsis, the goal with sepsis is trying to predict sepsis. Who is septic and who is not? Because sepsis can indicate that you have bacteria in your blood called bacteremia, and obviously bacteremia is bad. So we use SIRS criteria to try to predict who is going to have sepsis. And SIRS criteria uses 4 measurements. You have to have 2 of these 4 measurements. So we use temperature. So being hypothermic or hyperthermic with or febrile, to have a temperature greater than 38 degrees Celsius, to be tachycardic with a heart rate greater than 90, tachypneic with a respiratory rate greater than 20, or to have an elevated white blood cell count greater than 1200, or a low blood cell count greater than or less than 4000. If you have 2 of these criteria and you're concerned about an infection, that patient could be septic, and it requires a further evaluation with labs. And usually it's to expedite treatment as well, to say, this patient could have a serious infection. Let's start treatment right away. So our patient ended up having Borehov's, obviously with a hole in the esophagus, you're leaking contents into your chest cavity, which can cause an infection and sepsis. We can do a further evaluation though for our patient. We can get some blood work. These are common blood tests that we do. And again, I'm not going to go through all of them. CBC is one of the most common ones, as well as CMP, which I'll touch on in just a second. Creatinine and BUN, this will be included on the CMP, but that gives you an indication of kidney function. Lipase is an indication of pancreatitis. Troponin, I do want to touch on. So we talked about earlier, if you get a blockage in your coronary artery, you're not going to get oxygen to the muscle of the heart. The muscle of the heart is going to start to die. And when it starts to do that, you're actually going to start leaking troponin. So that's what we measure when we're trying to decide if a patient has had a heart attack or not. A UA just tells.
Is that a one-time test, or should it be done in a series?
Yes, it should be done in a series. So if I have a heart attack, like right now, technically the troponin can be negative. It takes about 2 hours for it to build up in the blood to be positive, which is why we also, if you look for those EKG changes, because you don't want to wait 2 hours for intervention if you feel like it's a bad heart attack. And I've had that where the patients have ST elevation, true STEMIs, true heart attacks, and their initial troponin is negative, and then after the cath lab and everything, it's obviously higher. A UA is just a test for a urine infection, and then a lactate. This, again, tissues need oxygen. If they don't have oxygen, they will start to release lactate. So lactate can be signs of tissue hypoperfusion or shock. So this is just a normal CBC. I'm going to go in depth a little bit more on a CBC later. These are just some normal values for your reference. A CBC is going to have a white count, a hemoglobin, which is red blood cells, and platelets, which are clotting cells. And then a CMP. CMP gives you a lot of information. It tests all your electrolytes. These are just reference values of electrolytes for you. These are some more electrolytes. Sorry, I'll go through them real quick. Sodium, potassium, chloride, glucose. And then this is calcium and we call it bicarb. Then CMP also gives you your kidney function, which I touched on earlier. And then your liver function, which I'll go in more depth a little bit. So the CMP gives you a lot of information. Lastly, we do obviously imaging studies in the emergency room. You saw an ultrasound of the heart called an echocardiogram earlier. You saw a chest x-ray earlier. They did show you a few CTs. We don't use MRI very often in the emergency room. Under rare circumstances, we can, and then we don't really use PET scan in the emergency room, but these are some imaging studies available to us. Oh, the patients always want to know when they come to the ER, can I go home? Obviously, our septic patient with Borehof can't go home, but there are patients that are safe to discharge home. You don't have to know these. This is just to kind of introduce that there are screening tools that we use as ER doctors to say, to give us an inclination if patients are safe to go home. And these are just based on medical studies. The heart score is for a patient who comes in with chest pain. Canadian syncope score is obviously a patient who comes in who passes out based on our studies and stuff. If everything looks okay, you can risk stratify if they're safe to go home. And the CURB 65 is for patients with pneumonia. This may be a good time for a break.
Doctor, can I, before we break, I just have, that was excellent, by the way. Going back to the oxygen saturation levels, okay? And when we're looking at O2 sat, when we look at records, we always see an O2 sat reading, and it would be RA on room air, or it could be supplemental oxygen, right?
Yeah.
So what I would ask you to do, because that's typically what we, we'll see that. And so maybe if you could just quickly explain the difference between the two of those things. And the second thing, we had a question about how the O2 sat can change so drastically from 1 minute to another. In other words, if the patient is on supplemental oxygen, let's say, and has a very low O2 sat on supplemental oxygen, and then gets to the emergency room or gets to the hospital, and now they're on room air and they're at 99. How that's possible and how that happens.
Yeah, so it kind of goes into physiology a little bit, but in regards to the first question, room air versus supplemental oxygen. So don't quote me on this, but the oxygen that we breathe is only, the air that we breathe is, I think, only saturated with like 21% oxygen. So when we put patients on oxygen in the hospital, we're giving them 100% oxygen right to their nose. So there's more oxygen molecules for the red blood cells to hold on to. And it makes it easier for the red blood cells to hold on and get oxygen. I hope that answers the question. So that's why supplemental oxygen can help. It overloads that hemoglobin. So if you, because let's say you had a low blood count. Let's say your hemoglobin was like 6. That's super low. That's really low. Their oxygen saturation is can still be 100% because all the red blood cells have oxygen on them. But if you have, a hemoglobin of 12, which is normal, but a blockage in your pulmonary artery and you're only using one lung, all the blood that's circulating, that half a lung can only do so much. It's only going to grab a little bit of oxygen. And so when we measure it, all the red blood cells, even though they have a lot of red blood cells, they don't have enough oxygen connected to them. So if we give oxygen, that one lung can do a lot more work, and the red blood cells can grab all that oxygen and deliver it to the tissue.
Okay.
And then the second question was, how can it change? That's a hard question to answer. When we talk about oxygen saturation, it's so much easier for us in the emergency room because the patient is hooked up to a monitor. Now there's a waveform. So obviously it's just a little measure device on the tip of the finger. It can get hit. If you tap it like this, like it'll be abnormal. So we're looking for a waveform, and you want it to be a good waveform, which says like every beat of the heart, we're getting this oxygen saturation. And that tells us it's an accurate oxygen saturation. I'd say most commonly when patients come in by the ambulance, they just put the patient on oxygen because their pulse oxes aren't as accurate as ours, or their waveform wasn't accurate. And now with patients have their own at-home oxygen monitor, and obviously they're not as good, not as accurate as the emergency room. That's, I'd say, the biggest explanation as to why we see such a discrepancy.
Okay. All right. Thank you.
Yeah.
Okay, so I was just answering a question in the Q&A. And keep the questions coming. We appreciate them. But this is a good time to take a quick 5-minute break, but I do have to give you the first code before we take the break. And that first code is summer. So it is now 6:52, 6:53. Let's be back here at 6:58 so that we can get promptly started at 7 o'clock to go over the next 2 patients. Okay, it's 6:58. I wanted to touch on some of the things that Dr. Hawkins was talking about. One of the things nowadays is electronic medical records. And sometimes everything is not really all where it's supposed to be. And even though an emergency room record generally doesn't have, at least not in my experience, flow sheets, that usually all the vitals are documented in the emergency room chart itself. But sometimes you have to look at the flow sheets to find really pertinent information. And a very major important thing, especially when we're dealing with personal injury cases, is you want to know the patient's pain scale. And you want to make sure that that pain scale, how it was charted throughout the ED visit. And obviously, if it's an admission, how it was charted throughout the admission. You want to see, was the patient given morphine to reduce the pain scale? At what time? All of these things can be found in the chart so that you have a better understanding. Wow, my patient had, or my plaintiff had a pain scale level of 9 until they were given, an intramuscular injection of or however you give morphine, until they were given morphine, and then it went down. But then as soon as a certain amount of time wore off, it jumped back up. So you want to know those things when you're dealing with your case so that you know how much pain your patient was in. Additionally, all of your vital signs should be monitored, and that could be an indication: elevated heart rate, elevated respiratory rate. Those could be indications of anxiety. They could be indications of pain. You want to see if there's a correlation between those abnormal vitals and the pain scale that's reported by the nursing staff. So that's all ways in presenting your case, building your damages, and trying to get the best amount that you can for your case.
Any other questions before we start?
I think there was, since we have sepsis still in our head, still fresh, there was a question about where really the protocol, what is the proper ER protocol when sepsis is suspected? So let's say white blood count is very, very high, and the other numbers are pretty much okay. Not high, not low. What is the basic ER protocol?
That is a good question. It changes. It's been changing just even in my time doing this, but the goal is to identify sepsis. So if they meet Sepsis criteria, and you say, they came in for stomach pain, which we'll go through, and you do just the basic labs. You don't do sepsis labs, which I'll touch on a little bit. And then you find, oh, well, their heart rate was 92, and I get their white blood cell count back and say it's like 16. It's like, oh, they do meet Sepsis criteria. You would want to add additional labs, which I will go into detail a little bit, but like a lactate, like blood cultures, and you'd want to initiate. Most ERs now have a sepsis order set, so you'd want to initiate the sepsis order set, which is what I'm going to talk about a little bit more. And then you'd want to treat it right away, and then you'd want to give antibiotics right away, and then you'd want to try to prevent the patient from getting worse, right? So that would be antibiotics, and that would be fluid. And it just kind of keys you in to monitor the patient more closely as well, to say, this patient does have a severe infection. Let's make sure that we're hydrating them well. Let's make sure we're getting those antibiotics as scheduled, like we're supposed to.
So to further that question, you have a patient with an elevated heart rate and an increased respiratory rate, and you've given them 2 bags of IV fluid, and you've retested them again, and their heart rate is still elevated. So that's pretty much ruling out dehydration as a cause of the elevated heart rate and the respiratory rate. So at that point, am I wrong? Correct me if I'm wrong. At that point, you have to take the potential of sepsis a little bit more seriously.
Yes, a heart rate that doesn't decrease, you'd want to say, are we missing a fever? Like, are we not measuring their temperature correctly? Or is there something else going on?
And explain to them what is overwhelming sepsis.
So there's sepsis and there's sepsis with severe features. Sepsis with severe features is going to be that kind of end organ damage that we talked about. So signs of where the tissues aren't getting enough oxygen because you're starting to get the distribution of the fluid that should be in your veins and your arteries. It's going to start distributing to the outside. And so you aren't going to have enough blood volume. So you are going to start getting a fast heart rate. You are going to start not perfusing your important organs like your kidneys. So your kidneys can start to fail. You're going to stop perfusing your liver. So your liver can kind of shut down. You get these signs of end organ damage. And that's what we're looking for when we do more sepsis-based labs. Yeah.
Okay.
And I'm going to go into sepsis in depth here in just a little bit.
Now it's time to move on to our complaining stomach patient.
Yeah. So we just did the chest anatomy. Now we're going to do the abdominal anatomy. So our patient with stomach pain. When we talk about patients with stomach pain, it's important to localize where the pain is because based on the anatomy where their pain is, it can kind of help us understand what's causing their pain. Let me click here. So again, the right side is the left and the left side is the right. This is just basic anatomy. We just talked about the esophagus here. The esophagus feeds into the stomach, which is right here, kind of in the middle, off to the left just slightly. On the right side of the body, you're going to have the liver and the gallbladder. And then hiding behind the stomach, you're going to have the pancreas and the spleen's kind of tucked away back here. From the stomach, you're going to have your small intestine. And I think you guys are going to get a more in-depth kind of stomach colon lecture later. Small intestine, and the small intestine turns into the large intestine, which goes up, over, down. This slide is really in depth. It's just to show you how we divide the abdomen, and I'm going to go into all of this in just a little bit. Again, this is just kind of to show you how we divide the abdomen into its different quadrants. This slide it's again a little complicated. It's just to show you that the organs are not just kind of floating around in there. They're covered by something called an omentum. And this omentum is created by a lining called the peritoneum. That's just to show you that the abdominal cavity is divided into peritoneal organs and retroperitoneal organs. So this greater omentum kind of overlies your peritoneal organs, but it creates a retroperitoneum, which is this space right here. And this is like a front view of those retroperitoneal organs. So you can see your kidneys are back here. These are your adrenal glands, they sit on top of the kidney. Your pancreas is actually retroperitoneal. You can see it here. And then parts of your colon and parts of your small intestine are also retroperitoneal. This picture also shows that aorta, because remember, the blood tube is super important. It runs throughout the entire body. So this is the aorta. And then this is the inferior vena cava that goes all the way up into the heart, like we talked about earlier. So moving on, this is kind of focused in on the right upper quadrant. So your liver and your gallbladder most commonly cause pain in the right upper quadrant. This does show the pancreas, but I do want to say that the pancreas inflammation or pancreas pain typically presents with pain in the left upper quadrant and in the back, and I'll show you why a little bit later. But the liver and the gallbladder actually drain together. So the liver metabolizes stuff and the gallbladder secretes bile, and they drain together here into this little duct. But the pancreas also comes and attaches, and it drains together. These three things drain together and empty into the small intestine. Medicine's all about blockages. So just like you can get blockages in your arteries, you can get blockages in these ducts. The gallbladder can produce gallstones, and if for whatever reason they get out, it can cause a blockage here, which anytime an organ is blocked in medicine, it's going to get infected. So if you have a blockage here, the gallbladder is going to get infected. That's called cholecystitis. Hepatitis is a little bit different. We're not going to touch on hepatitis today. But you can also get a stone down here. And so you can get, it will affect your gallbladder, it will affect your liver, and it will affect your pancreas. And you can measure the levels kind of the liver and the pancreas to see if there's a blockage here.
Is that the common bile duct?
Yep, the common bile duct is the gallbladder and liver, and yeah, pancreas together. The cystic duct is going to be the gallbladder duct, and then there's a common hepatic duct, which is just the liver. And you can measure, so on ultrasound and stuff, they'll measure like the CBD and they'll say like it's enlarged. We think there's a stone stuck in there. So then we're going to move on to this is the right upper quadrant. We're going to move on to the right lower quadrant, which sits down here. And this is going to be, if patients come in with right lower quadrant pain, we're going to worry about the appendix. This is a really good picture. So you can see the small intestine comes around and it turns into the large intestine. This junction is called the cecum. It's also where the appendix sits. It's just this little appendage off of the colon, doesn't really have a purpose that we know of. And it can get blocked. It actually gets blocked by something called a phlebolith, but it's basically just like calcified stool and it gets stuck right here. And so anytime anything is blocked, it's going to get infected. So the appendix gets enlarged and gets infected. This is a CT. I don't expect you to be able to pick out the appendicitis on this CT. There's what we call an arrow sign showing us right where the appendix would be. But I just think this is a really good picture of the anatomy. So you can see the heart here. On this window, air is dark. So you can see the lungs here. This is the liver. And you can see the gallbladder. This right here is the gallbladder. And then this patient likely drank contrast, which is why their colon is so bright white. But you can see the colon really well here, and you can see the bladder. I just think that's a really good CT. Moving on, so we talked about the right upper quadrant, the right lower quadrant. We're going to move to the left upper quadrant. And this is where you usually get that pancreas pain, just because the pancreas kind of wraps around and it's retroperitoneal. So you'll get patients will have left upper quadrant pain that wraps around to the back. The spleen also sits here. The spleen doesn't usually cause too many issues. It can get enlarged for various reasons. And then specifically with trauma. So if you have a cut in the spleen from trauma, the patients will have pain kind of in the back and in the left upper quadrant. This is just another CT to kind of show you the anatomy. So this is the liver over here. This is the gallbladder. It looks much bigger here. It's just the way the CAT scan kind of cut the patient. And we're looking like down on top of the patient, kind of cut in half. You can see the pancreas again. This is the left side of the body over here, right side of the body. The pancreas wraps around back here. This is the spleen right here. And then you can see kind of, oh, this is the aorta right in the middle. And then you can see the kidneys here. So to touch on the kidneys a little bit, they actually sit quite high. They are protected by the rib cage. So they do sit kind of high up in the abdomen, and they are connected to the bladder via these things called ureters. So you can see the ureters kind of run the length of the abdomen. So patients with kidney stones, if you've ever had a kidney stone, they can have pain all along this ureter. So you can have back pain, you can have pain on the left side in the middle of the abdomen, you can have left lower, right lower quadrant pain, you can kind of have pain anywhere with a kidney stone. If you get a kidney infection, typically that will present with back pain. If you get a urine infection, a urinary tract infection, that typically presents with pain in the suprapubic area. And so when we talk about suprapubic, it just means supra, above the pubis. And that's generally this region. Again, it can present with, or you can have pain there due to a urinary tract infection, or kidney stones can have pain there. Just like you can have pain in the middle of the lower abdomen, you can have pain in the middle of the upper abdomen. So that's called the epigastrium. It's just below your kind of sternum, right in the middle of your rib cage. All kinds of things can cause pain there. Most commonly, the stomach sits there. So you can have inflammation of your stomach. That's called gastritis. GERD just means gastro, stomach, esophageal, right here, reflux disease. So you can just have acid that kind of refluxes up and causes pain. Or you can have peptic ulcer disease. And the stomach, I always like to say the stomach is kind of lined with the same thing as our cheek. So if you have too much acid in the stomach, it'll wear away that lining and create an ulcer with exposed nerves and soft tissue. So if acid splashes on that ulcer, you're going to get pain right in the middle, and it can be kind of an intense pain. But because the gallbladder and the pancreas are also so close to the epigastrium, you can get pain from those in the epigastrium as well. But our patient, he is having pain on his lower left side. So back to our anatomy, when we're looking at the lower left side, the end of the colon sits there. So this is the ascending, so ascending colon going up, transverse colon going across, and descending colon going down. And the left side of the abdomen, worry about the descending colon. The colon can get something called diverticulosis. And the colon should be really smooth like this. This is a colonoscopy camera in the colon. It should be really smooth. Well, you can get outpouchings called diverticulosis, and they look like this, little outpouchings in the colon. They're pretty common. The older we get, they can be common. The problem is these can get blocked with seeds or food or whatever. And remember, if something gets blocked, if an organ gets blocked in medicine, it's going to get infected. So most people have diverticulosis, but when it gets blocked and infected, it's called diverticulitis. Back to our patient. So he has a fast heart rate and he's breathing fast. And we think he has diverticulitis based on where his pain is, which is an infection. So he does meet SIRS criteria. So I just want to touch on, I'm glad people are excited about sepsis, because I wanted to kind of bring it back to sepsis because I think it is important. So our patient meets SIRS criteria or sepsis criteria. So we would want to do a little bit bigger of an evaluation on him. We would want to do some blood work. So we talked about a CBC. A CBC is going to tell us the white blood cell count, which are called leukocytes, a hemoglobin, which is like your red blood cells, and your platelets. Leukocytes, WBCs, the most basic term is called like your infection fighting cells. When you get a CBC, they're going to be split up. You're going to have a differential of all the different types of white blood cells, the leukocytes. There's basophils, eosinophils, monocytes, and lymphocytes. What I want to focus on is neutrophils. So typically, neutrophils fight the bacteria. So if you have a high percentage, a normal percentage of neutrophils is 40 to 60. Say you have 70% neutrophils. That kind of clues us in that maybe the patient is fighting a bacterial infection. But even more concerning, if you get a CBC and it shows bands, that's when I get really worried about a severe infection. A band is an immature neutrophil. So the body's basically saying this infection fighting cell is not even ready, but the infection is so severe, I'm going to send whatever I have prepared to fight this infection. Technically 0 to 5 bands is normal, but I get worried when I see even any percent bands, because it's telling me, why is the body releasing these infection fighting cells that aren't ready? Because the infection is so severe. We're gearing up to fight this infection. So let's say we do think our patient does have sepsis. There's sepsis with severe features, and then there's septic shock. Sepsis with severe features, like I kind of mentioned earlier, is signs of end organ damage. So again, for whatever reason, maybe because our body is fighting this infection, whatever reason, our organs are not getting perfused like they should. They're not getting oxygen, and they're starting to die, for lack of a better word. So your kidneys can become affected, and your kidney function levels will start to go down. Your liver can be affected. And so your liver enzymes it's called shock liver. You can have liver enzymes go elevated. The PT and PTT, so these are clotting cells. It's actually a test. We can test how quickly your blood is clotting. Gets a little complicated, but the liver also helps in producing things that help our blood clot. So if you start getting abnormalities in clotting function with sepsis, that is a sign of severe sepsis. That can kind of clue us in, like, this patient's can get really sick, like we have to intervene quickly. By intervene quickly, it means get them hydrated. We give patients that we're concerned about sepsis with severe features lots of fluid. So we actually give them 30 milliliters per kilogram of weight of fluid. And then a lactate, again, we touched on earlier. If the tissues aren't getting oxygen, they're going to release lactate. And then blood cultures. So this is basically a test. You don't get the results back right away, but remember, sepsis can indicate bacteremia, bacteria in the blood. So blood culture, you literally draw the blood, you put it on a little medium, and you just see if the bacteria grows to see if they truly have bacteria in their blood. Those results take anywhere from 24 to 72 hours to come back. But the reason that's important is because once the bacteria grows, we can say like, oh, it was E. coli, or like it was this bacteria. And then you can test it to see what antibiotics are good to treat that infection. So this is a little bit more on sepsis.
But initially you would start with a broad spectrum antibiotic, correct?
Yes, exactly. One that covers kind of everything, and then you can narrow it down. And then liver function tests. So I mentioned kind of shock liver. It gets a little complicated, but basically bilirubin is cleared by the liver. So these levels should be low. AST and ALT are kind of like troponin, like if the liver starts to get damaged, you'll see these increased. Alk phos, it can be elevated for many reasons. Sometimes it's artificially elevated in kids, but sometimes it can be released from bones. So alk phos is not very specific, and lipase is very specific to the pancreas. Amylase, they used to use it a lot for pancreatitis, but it's kind of like alk phos. It's not very specific to a specific organ, so we don't use it as much. So imaging, we can obviously use our CT again. So we get a CT and our patient has diverticulitis. Again, I just want to show you it's in the left lower quadrant there, and there's some inflammation. So our patient has diverticulitis. We have one more patient to go through. This one's going to be a little bit more brief. So we talked about the chest cavity, the abdominal cavity. Now we're just going to touch slightly on the brain. We have a patient with facial droop. We're back to blood vessels. So remember, every organ needs blood supply, needs oxygen. So this is the blood supply to the brain. It looks a little crazy, but this is the aorta. So this is that blood tube that we talked about earlier. Right where the aorta curves, it has branches off of it. And those branches, so your aorta sits right here. Those branches end up forming the carotid arteries. And the carotid arteries go up to the brain. There's actually, gets complicated, but then there's subclavian arteries, and then those arteries branch in the back and they form vertebral arteries. And all four of these kind of come up to the brain and form the blood supply to the brain. And they actually form a circle kind of deep in the brain called the circle of Willis, which is pretty crazy. But just know there's a lot of blood supply to the brain. It branches off the aorta. And just like you can get a blockage in any artery, you can get a blockage in these arteries. There are three main cerebral, so cerebral meaning brain, arteries that we talk about. They're pretty easy. So posterior, meaning the back of the brain, anterior, meaning the front of the brain, and the middle of the brain. So those are actually one thing in medicine that are named appropriately. And these supply very specific parts of the brain, and we know what these parts of the brain do. So when a patient has a stroke, we actually do a very detailed exam to try and figure out where the blockage is based on their exam findings, because we know what each part of the brain does. There are two different types of, so when you get a blockage, that's called a stroke, but there's actually two different types of stroke. There is a hemorrhagic stroke, which is a bleeding stroke, and there's an ischemic stroke, ischemic meaning lack of blood, lack of oxygen, which is a clotting stroke. So here's an example, basically a clotting stroke. You're going to get a blood clot somewhere along the cerebral artery system. And then a bleeding stroke is basically, there's a lot of layers to the brain here, but basically you get blood in one of the layers of the brain. So for our patient, he's got facial droop. We're going to do a very detailed exam. This is, I just wanted to put these up here so that you have an idea. There are screening tools we use. So a FAST exam, it's kind of taught just so that we can quickly screen a patient to see if they have a stroke. NIH applies a numerical value to the patient's symptoms, and we do use this in the emergency room, but these are more screening tools that we use to identify if a patient's having a stroke so we can get them to CAT scan right away. But as a provider, what we want to do is a detailed exam. Whenever patients or physicians are asking patients like close their eyes and open their mouth and smile and everything, we're testing the cranial nerves. And again, that's to try to localize the stroke. We test everything, make sure strength is equal on both sides, make sure the sensory is equal on both sides. just to try to kind of identify based on what function they have and lack of function they have, where that stroke could be. So we do CAT scans for strokes. I do want to point out, so if a patient has an acute stroke, a stroke, let's say clotting stroke, an acute ischemic clotting stroke, and they come to the ER and we do a CAT scan, you cannot see an ischemic stroke on a CAT scan. We do a CAT scan to make sure there's no bleeding stroke, and that's because of the treatment, and I'll go into that in a second. But the next CAT scan I'm going to show you, so this is an MCA stroke, a middle cerebral artery stroke. This is what happens days after you've had a stroke. So this patient had a stroke previously. This is not necessarily acute, meaning like within the 4 hours that I care about in the emergency room, this patient had a previous stroke.
So
Same
the
thing.
darkened area is dead brain tissue, correct?
Exactly. Or even like swelling, like a little bit of edema as well. Because once the tissue starts to die, just like if you hit your arm really hard and you get redness and swelling, when tissues, that's tissue damage. When your tissue starts to die in your brain, you're going to get swelling and inflammation in the area. And this is the same thing. See this little darkened area? That's a posterior or PCA stroke. So those are clotting strokes because you have lack of oxygen, dead tissue, swelling. A bleeding stroke is much easier to identify. This is a bleeding stroke. So blood is bright white. This patient, one of their arteries, like, either had an aneurysm and ruptured, or for whatever reason, ruptured and had bleeding into the brain. And again, we care about this because if you have an ischemic stroke and you come in and you get a CT and your CT is negative, we can give a medication called TPA. And TPA, we call it a clot busting medication, but basically it breaks down the fibrinogen, it's okay, in blood clots to help them disperse and break up. Now, TPA is a very dangerous medication because, it's important for our body to kind of maintain homeostasis with like bleeding, clotting. When you give TPA, you can have spontaneous bleeding. So it is a dangerous medication. So we actually have a very specific patient and time frame that we give it in. We like to give it within 4. Now they've kind of stretched it to 4.5 hours of stroke symptom onset. So if someone went to bed and they woke up and they looked like they'd had a stroke overnight, you can't give that medication because you don't know when they were normal. But if I'm having lunch with you and you looked at your clock and it's 12:15 and you saw my symptoms start, and you can get me to the hospital and everything, we can give that medication as long as it's been within 4 hours. Hospital systems like to do this better though. If you come in for stroke-like symptoms, they do like to get everything going really quickly. And most hospitals have we call it door to TPA. So the time you rolled in through the door to the time you got that TPA, we like to kind of condense that to an hour to try to break up this clot and save whatever brain tissue we can. So that is all I have. This is just a quote. Medicine is a science of uncertainty and an art of probability. This is a quote from, I think, William Osler. Dr. William Osler was like a Canadian physician, and he started one of the first medical residencies.
And is that where the phrase came, when you hear the beating hooves, think of a horse and not zebras?
Exactly. We always say common things are common. And if you hear hoofbeats, think horses, not zebras, right? We try to focus on the common things. Another quote of Dr. Osler, I did not put this one on there, but it says, he has a quote that says, it's astonishing with how little reading a doctor can practice medicine, but it's not astonishing how badly he may do it. So read and study.